medical officers, the chief medical officers of the GH, we provide them. And we also now going ahead with accreditation of 12 of our government hospitals through the Quality Council of India. We also have the biomedical engineers for equipment, for reducing the downtime equipments, and they are functioning in the districts. The CMONG Center, here I like just to mention one thing about whenever we provide services, equity is one thing which we shouldn't forget. If you see that, one thing I like to mention on the slide is when we opened the CMONG Center, our major thing was to cater to the complicated maternal admissions. It was around 4,17,000 in the past 1 year. See, out of the 4,17,000, 37% belongs to the scheduled caste and scheduled tribe community, which is any welfare government would also always looks into equity, and I think we are doing well in that particular regard. The tribal outreach program, very dedicated NGOs go to the inaccessible areas, either by a van up to wherever the road ends, and from there by foot. And so far we have had around 6,59,000 on OP. And very, very importantly, in the district of Ooty and some places of Vellore, we found that the tribals are suffering out of sickle cell anemia. So we provide them with screening, and treatment facilities also are provided through them. Very importantly, poison treatment. This is one thing which is actually forgotten. Various types of poisoning are there. So we trained many doctors in nearly 34 poison treatment centers. We saved a lot of lives. In fact, 51,722 lives were saved in the past 1 year. And for this now, we are going to upscale it to another 32 more centers so that we improve access. So the patients can be transported through the ambulance, 108 ambulance, and we provide infrastructure facilities. And we also want to establish ICUs, well functioning ICUs, for which we are going to procure a lot of equipments, and centers would be functioning. Now coming to the E factor, the HMIS, we have established the health management information system and hospital management information system. This is one thing where this group would be interested. Now we have established in 42 hospitals and functioning well. And this is going to be upscaled to nearly 222 hospitals, and the tenders are all on, worth of 84 crores. And we are also going to upscale it to the medical college institutions and the Dr. MGR Medical University for research purposes, using this data which is emanating from the health management information system. So that will be to the tune of another 50 crores. So here, this is going to lead into a state health data resource center, which is going to capture all the data, do a lot of research, and advise us in evidence-based planning. Now, I have already told you, real-time data is being made available, and very importantly, we got a government order doing it with manual registers. We still have problems with our staff, but in the long run, I think we'll be able to do it with all the manual registers. And I told you about the State Health Data Resource Center. This is regarding the Tamil Nadu Medical Service Corporation. All the procurement of drugs and equipment is done through them. We have the essential drug list, and we have various district warehouses through which these drugs are all supplied. Very importantly, when you bring in technology, the entire thing is on a software technology. Simplified deleting facilities have to be done, and proper transporting mechanisms have to be done, or else we will not be able to supply these drugs properly to the intended people. And we always ensure quality of the drug procurement. One important thing is we are able to increase the cost effectiveness of our procurement. As far as the vaccine supply are concerned, we ensure that we have 1.5 months stock, and based on the first in and first out principle, which is followed in all the storage points, the temperature chart is ensured by maintaining a cold chain system. As far as the work health force is concerned, we have compulsory rural postings so that access and equity is taken care of, as well as quality. We ensure that the vacancies are kept below 5%. So to prop up the working of the doctors in the rural areas, we provide them additional marks when they want to come into the PG, when they want to study for the PG graduation. And we have also rationalized the service norms and staff norms for functioning. So this brings in the performance-based planning. If you rationalize their norms as far as the OP or what is based on performance, so we do that. So there is a reservation of 50% of PG seats for in-service doctors. So that is an incentive for them to come and work for the government, and full salary for the government doctors undergoing PG. This is, and very importantly, for any workforce, if you want a very strong workforce, you have to have medical institutions providing that workforce. So I think in the past 10 years, we have opened as many as government colleges as in the private medical colleges. We have around 19, 2 are underway, 17 plus 2, and for quasi-government is 1, and 14 self-financing colleges. As far as capacity building is concerned, I think I just mentioned in the slide, I'll just skip this. We provide anesthesia training and emergency obstetric care. A lot of trainings have been given. Now we have, as I told you, about the public health cadre. Now we want to bring out health administrators who do very good in health economics, because I told you about the state health data resource center. Now we want, and I also talked about evidence-based planning. So we want health economists, hospital managers within the government setup. So for which now we are tied up with Tata Institute of Social Sciences, and just 2 days back we got the approval of sponsoring 10 people, 10 of the doctors, deputy directors who are in the public health department or in the medical service, other medical services, to be deputed for training in this particular course. So through which we will be again showing the way for this country to having solid group of people who can interpret the data and show us evidence for policy making. You can see the health budget has been steadily increasing over the period of time, and we have this Varmun component. Prevention is better than cure camps, and the Kannoli, the eye program, and the Kalina insurance scheme. As far as quality is concerned, I have already mentioned all this. So as equity is concerned, no use of fee for anybody in Tamil Nadu, anybody walking into the medical college institute for any type of surgery, either the cardiac up to ordinary fever, there is no use of fees. As far as the Kalina insurance scheme is concerned, so we have done 1 year. We are now provided support, right from, this is the support, we are like from cardiac diseases to oncology, hematology, orthopedic, plastic surgeries, so nearly 16 various diseases. We have provided support to nearly 1,62,000 people. So these are all, not only the people, we have also covered a particular section of the APL families. Very importantly, we are able to regulate the market rates for hospital, for the healthcare, and we are able to provide, increase the quality of service through the private hospitals. We have covered around 1 crore and 36 lakh families in this particular program. Excuse me. As far as the 108 ambulance service is concerned, we are transporting nearly more than 8 lakh people in these ambulances the past 1.5 years of functioning, and very critical care patients. If our support was not there, they would have died. It was around 25,000. And we are also now providing 37 dialysis units in all the district headquarters hospital. And the imaging service, which I like to mention, we are going to procure digital X-ray machines in all the district headquarters, around 50 in number. And we want to link all these services to one particular center where we will place radiologists. Radiologists is a big problem for us. So availability of radiologists is a problem. So this imaging service is going to be linked at the cost of 21 crores. If you see whatever efforts we have taken, the maternal mortality rate has decreased. There is a decreasing trend in the infant mortality rate, 49 to 31. If you see the domestic delivery has gone down, the institutional delivery has gone up. Very importantly, if you see the private sector, most of the people now shifting to the public sector. So that is a good shift. And in fact, because of the state-of-art technology we have in the government sector, we are not competing with each other. We are just providing substitute services. Many of the people come to the government sector for using our ultrasound and all those things and go back and get the treatment from the private sector. So this is 99.8% is the institutional deliveries, for if it's a mark for our performance. Some of the media reports. Average OP per PHC, if you see, it has gone up from 79.4 in 2001 to 148 in 2009-10. Immunization, vaccination coverage and polio cases. Measles, how the rated DPT vaccine, how the DPT, all the cases have gone down. And I think, and our state got the non-focus state, it got the first surprise in the implementing NRHM program. But we still have challenges: the slow decline of IMR, stagnant NNMR, then MMR in high and poor socioeconomic groups, lack of really specialist manpower, cardiologists, radiologists. This is all concern. They all move to the private sector, and urban health infrastructure is a matter of concern which we'll have to tackle. Thank you.